Good morning, students. Today I'll be starting the chapter of hemodynamics. So, this comes as a chapter in general pathology. And as I go ahead, I'll be explaining to you what all questions you can get, whether it's going to be a essay question or it's going to be a short or a very short. Okay. So, those of you who have got your registers with you, uh, books, so take some notes. Okay. So, what was the impression when you saw the picture which I had just put? It was red. Okay. Those flowers were all red. It was an intentional slide which I had put to depict that hemodynamic disorders I'll be taking. What do you see here? You see branch of an arteriole and a venule. So, you will be dealing with it now. So the health of cells and organs critically depends on an unbroken circulation. Okay, so all of us have circulation, and you don't want it to be broken. So if it is broken, either we bleed to death or we clot to death. So either of these can occur. Blood delivers oxygen and nutrients to the tissues and removes waste from the tissues. So this is the balance which you see, that this is the demand and this is the supply. What is the supply? The body needs supply of oxygen and the organs demand it. So it demand has to be fulfilled by the supply. So what is the abnormality in the vascular flow, permeability or hemostasis with injury even in intact blood supply? So this is the blood flow. Yes, this is arteriole. Yeah, this is the arteriole. Blood flow is flowing. And this is a venule. Blood has to flow through the capillary bed into the venule. So, in this process, in the arteriolar end, there is filtration into the interstitial fluid and absorption of nutrients in the capillary bed. It goes to the venule finally. So, wherever there is an abnormality, the of various factors. So, what is the definition of edema? So, I always tell the students that certain definitions you have to memorize. Okay, you can't just sitting before the examiner say that there's no way. So, when somebody says define edema, it is increased fluid in the interstitial tissue spaces or body cavities. So, what are these body cavities? Hydrothorax, fluid in the pleural cavity, hydropericardium, fluid in the pericardial cavity, hydroperitoneum, which is commonly known as ascites, fluid in the peritoneal cavity. So, pleural, pericardial, and peritoneal cavity. Anasarca is where there is generalized edema with profound subcutaneous swelling. Okay. So, as we go ahead, you'll be seeing various features of this edema. So, what are the factors causing edema? Increased hydrostatic pressure, decreased plasma oncotic pressure. So here you can see that there is increased hydrostatic pressure, yes, decreased osmotic pressure, retention of sodium and lymphatic obstruction, increased vascular permeability as when it occurs in inflammation. Okay. Now, the next slide which I'm going to show is an expected question. And you're surely, I can say 100% you can get this slide, this question, if suppose it has not come for the previous batch. So this is nothing but exudate and transudate. So it should be done in a tabular column. So exudate, always remember, because of inflammation, and transudate is because of hemodynamic derangement. And pathogenesis, increased vascular permeability, and this is increased hydrostatic pressure or decreased plasma oncotic pressure. Specific gravity, remember, it's more because there is inflammation more than 1.020. Transudate, it is less than 1.01. So proteins, because again there is increased vascular permeability and inflammation, proteins are high, proteins are low in transitate. Cells are increased because again goes back to the inflammation and very few. So because of inflammation, again the cells are neutrophils, the lymphocytes and LDH levels are high, whereas in transitate we see mesangial cells and sometimes RBC appear in acidic fluid in malignancy. So the key points are inflammation and hemodynamic derangements, specific gravity is high, protein level is high, cells are increased. So all these are low in transitate. So cardiac edema. This is seen in cardiac failure because there is cardiac output decreased and decreased effective arterial volume, which leads to renal vasoconstriction. This again leads to tubular reabsorption of sodium and water and increased glomerular filtration rate. This again leads to renal retention of sodium and water and increased plasma volume, increased hydrostatic pressure, and finally edema. So we'll come to the decreased effective arterial volume. What does it lead to? Increased ADH. And this leads to increased renal retention of water. So when water is retained, increased hydrostatic pressure, finally we get edema. Okay. And wherever there is effective arterial volume decreased, it starts increasing the renin, aldosterone, and increased sodium and reabsorption. Okay. It also, yeah, let's skip this. Increase central venous pressure and increase capillary pressure. So, cardiac edema, how does it manifest? Prominent feature of congestive heart failure, particularly right ventricular failure. There is generalized edema, edema of dependent parts of the body, which is known as dependent edema. When do we get the dependent edema? People who stand for a long time, standing or ambulatory. So, here you can see that this is the dependent edema. Suppose a patient is lying down, the edema is in the sacrum. This is known as recumbent edema. There is a edema which is known as pitting type of edema. There is a backward failure where the failing heart dams back the venous return, resulting in venous pressure. Forward failure, decreased cardiac output. So these are all the features behind cardiac edema. So cardiac edema increases, yeah, we have gone through this. Renal diseases, nephrotic syndrome, renal failure, loss of albumin, and leads to decreased oncotic pressure, leads to edema. So all roads are leading to edema. Oliguria it results in retention of water, increased plasma volume, increased hydrostatic pressure, and edema. And increased renal vasoconstriction, renin aldosterone, increased tubular reabsorption of sodium and water, increased plasma volume, and edema. So, nephrotic syndrome, increased renal vasoconstriction, oliguria, and loss of albumin. So, renin aldosterone, tubular reabsorption, retention of water, decreased oncotic pressure, and edema finally. So, how does the renal edema manifest? Seen in acute glomerulonephritis, nephrotic syndrome, chronic nephritis, generalized edema, most evident in tissue that have loose connective tissue matrix. Prominent in the face, facial edema, especially around the periorbital region. This is the periorbital region, feature of renal disease. Tomorrow you come across a patient with edema in the face, your mind should strike that this could be renal edema. Okay. And if you see a patient having dependent edema, what could be the edema? It is cardiac edema. Okay. Just a rough tip to diagnose. So, edema in liver diseases and nutritional deficiency is generalized edema. What is the other name for generalized edema? It is also known as anasar. Yes, good. So morphology of edema, grossly, there is swelling of the organ with increased weight of the organ. Fluid oozes on cutting an organ. Sorry. Now we come to subcutaneous edema. Diffuse or more conspicuous at sites of highest hydrostatic pressure, influenced by gravity. This is dependent edema. And edema of different parts of the body is dependent parts is a prominent feature of congestive heart failure. Here, the finger pressure over the edema displaces interstitial fluid because, and there is a depression. I think you can see this. A finger is pressed, especially we have to do this over a bony point. Okay, so there is a pitting. This is known as pitting edema. Now, pulmonary edema. What has happened to the lungs here? There is fluid and the lungs are unhappy. Okay, pulmonary edema is seen in left ventricular failure, renal failure, acute respiratory distress syndrome, pulmonary infections, hypersensitivity reactions. Grossly, lungs are 2 to 3 times heavier, wet, repetent, and mainly in the basal regions of lower lobes. You can see the fluid. Cut section, frothy, blood tinged fluid escapes out. Once we put a slice into formalin while crossing, you find frothy black tinged fluid, which is a mixture of air, edema fluid, and RBCs. Okay. Microscopy. Septal walls are wide. This is a section of lung. Okay. Now you see that the septal walls have widened, blood vessels are dilated, granular pink precipitate within the alveolus. This is a pink precipitate, and there are micro hemorrhages. Can you see? These are the micro hemorrhages because the vessels are dilated. And hemosiderin. The macrophages are the scavenger cells in the body. Neutrophils are the soldier cells. So the macrophages, wherever there is some hemosiderin or some debris, they come and eat it. So you find macrophages which are hemosiderin laden, they are known as heart failure cells. Edematous lung is prone to infection. It is known as hypostatic pneumonia and brown induration. Be careful about brown induration because it is an important term. You may get it as a short or a very short question. So, can you see? There is, this is a septa, dilatation, and there is space, pink proteinaceous material, blood vessels are dilated, and hemorrhages. Can you see the hemorrhages? That means RBCs escape out of the blood vessel. And this is a pink precipitate. So, now a few words like I would like to talk to you about normal fluid hemostasis. So, all this while we were talking about edema. Okay. So, maintenance of vessel wall integrity, intravascular pressure, osmolarity, maintenance of fluid in a blood in a fluid state. I was telling you we can't clot to death or bleed to death. Just remember these 2 points. The blood can clot or bleed. So, you want blood to be in a fluid state, but it has to flow and it has to perform all its functions. So, producing a local hemostatic plug at the sites of vascular injury. Okay, this is normal hemostasis. So, vessel wall integrity, intravascular pressure, osmolarity, maintenance of blood in a fluid state, local hemostatic plug. So, what are the changes in hemodynamics? So, changes can be volume, pressure, protein content, endothelial function. Of these four, I would like to bank on the endothelial function, which matters a lot. Okay. Also, when we are going to talk about the cardiovascular diseases, I'm also going to talk to you about endothelial function. So, coming back to hemodynamics, volume, pressure, protein content, endothelial function. So, all this affect the movement of fluid across the vascular wall. So now let's go back to hemodynamic disorders, hyperemia and congestion. So increased amount of blood in an organ. Just now we were discussing edema, which is extravasation of fluid into interstitial spaces. Thrombosis is clotting of blood in living, in an intact vessel or the heart. We wouldn't like this to happen to any of us. Okay. Embolism is migration of the clot. Infarction is tissue death due to obstruction to blood flow. Shock is inadequate perfusion of tissues. Hemorrhage is inability to clot after vascular injury. I think you can remember all these terms if somebody asks you. Okay. So the shock is where there is inadequate perfusion of tissues. Hemorrhage is inability to clot. And edema, extravasation of fluid. Thrombosis is clotting of blood. Embolism of migration. Infarction because of embolism, tissue death. So, hyperemia and congestion increase volume of blood in a particular tissue. Hyperemia is arterial or arteriolar dilatation, which can be localized, physiological or pathological, seen in exercise or inflammation. And congestion is venous obstruction. See, if you look at the slides which I have put in, what is the color of the words which are coming? Hyperemia are put in red. That means it is arterial. Okay. Congestion I put in blue. That means it is venous obstruction. It can be localized or systemic and pathological. And obstruction by thrombus tumors can occur. Hyperemic or congested tissues are red, blue, and wet. Okay. Red, blue, and wet. So normal capillary bed. This is a normal capillary bed. So the blood goes out through this. This is the arteriolar. This is the venous. Normal blood Capillary bed is like this. Okay. Now, when there is hyperemia, what difference do you notice? There is less of the blue color, more of the red color. This is an active process. Augmented tissue inflow. There is arteriolar dilatation. Yes. So, increased blood flow and there is decreased output. So, increased blood flow due to exercise and inflammation. Affected tissue is red. Congestion. This is a passive process, results from impaired outflow from a tissue. What do you notice here? There is venular dilatation and it is completely blue. Part of it is red. Okay. So blood is gone, decreased outflow and local obstruction could be congestive heart failure, could be affected tissue is blue, red in color, which is known as cyanosis. Okay. So what are the circulatory disturbances? Normal arterial, capillaries, venule. Hyperemia and erythema, increased inflow. Okay. Congestion, cyanosis, everything is blue. Local obstruction, inside or outside, congestive heart failure. Just now what I have shown, it is in a pictorial form. So effects of chronic passive congestion in tissues. What happens? Tissues, there is congestion which is chronic and which is passive. So stasis of poorly oxygenated blood causes chronic hypoxia, which leads to parenchymal cell degeneration or necrosis, and necrotic cells are replaced by fibrous tissue. Okay. Capillary rupture leads to foci of hemorrhage and breakdown of RBCs releases hemosiderin. And what happens to the hemosiderin? It is taken up by the macrophages and they are now called hemosiderin laden macrophages. Okay, hyperemia is active, congestion is passive. Okay, remember this point. Hyperemia is active, congestion is passive. So acute pulmonary, hepatic, chronic pulmonary, hepatic. So acute pulmonary hepatic congestion and chronic pulmonary congestion, chronic hepatic congestion. So chronic venous congestion of liver, lung, liver, spleen. Either of this can come in the exam. Most of the times, every question paper, I am seeing that CBC lung or CBC liver, more common, CBC spleen, or these three can be kept as gross specimens for you in the practical examination. Okay, it's important. So, due to right-sided cardiac decomposition, due to left-sided. Right-sided enlarged, tense, cyanotic liver with rounded edges, congestion of the centrilobular sinusoids, atrophic centrilobular hepatocytes, say, congestion of the sinusoids, atrophic hepatocytes, markedly attenuated liver cell counts. Left-sided cardiac failure or shock leads to hepatic hypoperfusion and hypoxia, centrilobular ischemic necrosis of hepatocytes. So now combination of hypoperfusion and congestion leads to centrilobular hemorrhagic necrosis, variegated mottled appearance, sharp demarcation of viable periportal and necrotic centrilobular hepatocytes, red-brown depressed areas centrilobular, tan-colored surrounded areas periportal. So when there is hypoperfusion and congestion, centrilobular hemorrhagic necrosis, variegated mottled appearance, sharp demarcation of viable periportal and necrotic centrilobular hepatocytes, red-brown depressed areas centrilobular and periportal tan-colored. Whole thing is known as nutmeg liver. What is a nutmeg? This was a nut which was used in the pan by our grandmothers. They used to crack the nut and then use it along with the betel leaf. Okay. Then cardiac cirrhosis is because of centrilobular fibrosis. Is it clear? Now, what is a morphology? Acute hepatic congestion, central vein and sinusoids are distended with blood. Okay. Central hepatocyte degeneration and peripheral cells experience less severe hypoxia, only fatty change may be seen. So, causes are right-sided heart failure, especially when we are talking about chronic passive congestion of liver. Causes are right-sided heart failure, inferior vena cava obstruction, hepatic vein obstruction, and Budd-Chiari syndrome. So, you can see what all it can happen. Grossly, central regions of the liver, lobules are in brown, congestion, and long after it is a longer period. It's depressed, and nutmeg appearance. You can see here these are accentuated across against surrounding zones of uncongested tan liver. Okay, can you see this? Yes, this is a nutmeg. Microscopy, congested central veins and sinusoids. These are the sinusoids. Centilobular hemorrhagic necrosis. Because of the congestion, there is necrosis. And what happens whenever there is necrosis, the hepatocytes drop out, which is known as dropout necrosis. And whatever is left, the debris is taken away by the macrophages. Cardiac cirrhosis, you can expect this question. What is this? In long-standing cases, these necrotic areas are replaced by fibrous tissue. Okay, this is a special stain showing the fibrous tissue. Acute pulmonary congestion. Now we'll talk about the lung. Okay, we were talking about the liver. Morphology characterized by alveolar capillaries engorged with blood, associated alveolar septal edema, and focal intraalveolar hemorrhage. Okay. So, this is chronic passive congestion of lung with left-sided heart failure, tight mitral stenosis, obstruction to the pulmonary veins. So, you can see left-sided heart failure, tight mitral stenosis, and yeah. Grossly, you see that the lungs are enlarged, heavy and boggy. Does this look like a lung at all? Because lungs is slate in color, here it is blue red in color. Okay. On cutting, we take a slice of it, then frothy blood oozes out. Microscopy, initially alveolar capillaries are congested. You can see the capillaries here. Alveolar septal edema and intraalveolar hemorrhage. Septae are thickened. Can you see the thickened septae? Yes. Thickened and fibrotic. Alveoli contain numerous hemosiderin-laden macrophages, which are known as heart failure cells. You can sometimes get very short question on heart failure cells. So if you get it, you have to remember that these are found in the lung, and these are because of the chronic passive congestion of the lung. Okay. This is the, yes, you can see the septa, thickening, fibrosis. These are all the fibroblasts, okay? And these are all filled with hemorrhage and hemosiderin-laden macrophages. These are all the macrophages in which hemosiderin is there. Where does the hemosiderin come from? This comes from the RBC, okay? So, what is brown induration? I was talking to you about brown induration. This is important. So, brown induration is nothing but in long standing cases, lungs become firm, shrunken, and brownish in color. This is known as brown induration. Can you imagine? This looks like a liver actually. What a slate colored organ with a nice glistening serosa. It has become firm, shrunken, and brownish in color. So now we come to the spleen. This and this also can be given in the exam. What are the causes of chronic passive venous congestion of spleen? So cardiac failure, you can yes, and cirrhosis with portal hypertension, yes, portal vein obstruction, inflammation of the portal vein, which is known as pylophlebitis, and splenic vein obstruction, thrombosis, or compression by tumors in the neighboring organs. Yes. Grossly, spleen is enlarged to 1000 grams or more. Firm in consistency. Look at the spleen. It is enlarged and firm. Capsule which can be easily peeled off. Here it is thickened. Cut surface is meaty in appearance. Gray red to deep red. White pulp is indistinct. Cut section oozes dark red. Can you see this? Yes. Microscopy. The dilated and congested sinusoids in long-standing cases diffuse fibrosis, increased portal venous pressure causes deposition of collagen in the basement of sinusoid, areas of focal hemorrhage, organization of the hemorrhage, fibrotic nodules with hemosiderin, iron, and calcium deposition. So, siderofibrotic nodules or gamma Gandhi bodies or Gandhi gamma bodies, nodules. So, this gamma Gandhi bodies as such can come as a very short question. for 3 marks. So suddenly it comes Gandhi Gamma, Gamma Gandhi. You don't get surprised. This is nothing but found in chronic venous congestion of the spleen. Because of organization of the hemorrhage, there are fibrotic nodules with hemosiderin and calcium deposition. Okay. This again a special stain. Okay, so here we end this class today with edema and congestion and hyperemia. Hyperemia is arteriolar, congestion is venular, and edema is nothing but the presence of fluid in the interstitial space. So, as always, my classes I usually end with a quote. Success is the child of hard work, determination, and perseverance. Failure is a consequence of laziness, irresponsibility, and lack of commitment. Do you agree? Because success doesn't come suddenly, like just like that. Okay, it's a child. It's a child of hard work and determination and perseverance. And failure because you're lazy, irresponsible. There is lack of commitment. So as a result of it, what happens? There is success doesn't come, and you can't blame god, you can't blame anybody that you were not well. The commonest excuse given by students is I was not well, I had a function in the house and all that. But remember, you're all medical students and you should have the tenacity to stick to your schedules. Okay, so we'll meet again in the next class. Okay.